Okay, hello guys, welcome to Global Perfusion Community. So I'm Vivek Paul, I'm a cardiac perfusionist, and today we have Mr. Sachin with us, and he's going to talk on a wonderful topic that is hemofiltration during cardiopulmonary bypass. He's currently working at Narayana Health in India. He's from Bangalore, and he's going to present his topic that is hemofiltration during cardiopulmonary bypass. So I welcome Mr. Sachin.
Thank you, sir, for giving great opportunities. I'm Sachin. I'm working in Narana Hospital, Bangalore, India. Uh, I have 1.5 years experience in Narana Hospital. Today, I'm going to represent ultrafiltration techniques during CPB. Can I start, sir?
Yes, you can start, Sachin.
Okay, sir. Next slide. Welcome to Global Perfusion members. Thank you for attending here. So, next slide, sir. Topics I'll discuss. Today, I will today I'm going to discuss about ultrafiltration techniques during CPB. What are the topics I need to discuss? Definition and introduction, mechanism of ultrafiltrations, principle of ultrafiltration, indication and outcomes, types of ultrafiltration, and summary. So next slide, please.
Yes.
So definition and introduction. Ultrafiltration is a method used during cardiopulmonary bypass to remove excess water from the blood and make the blood more concentrated, like squeezing out extra water from a spoon. So next slide, please. Mechanism of ultrafiltration. We'll see step by step mechanism. Membrane with tiny holes, semi-permeable. A special microporous membranes allows only small things like water, sodium, potassium to pass through it. Big things like red blood cells and proteins stay behind. Next slide, sir. Pressure creates movement. When blood is pushed through the filter under positive pressure, water gets forced across the membrane to the other side, called the ultrafiltration side. The pressure difference is the driving force. Next, let's solute drag convection. So how water will pass. So as a water flows out, small dissolved substance like electrolyte follow the water. This is called convection solute drag. It is helps to clean out waste. Whatever patient blood we are getting, so we are during filtrations along with water, solute will pass. So this is called convections. Uh, this one here hydrostatic pressure will apply. So next, sir. What happens inside the ultrafiltration? Blood flow inside the thousand of tiny holes, fibers of filtering material. The fibers force are about 5 to 10 nanometer. It's very small. Pressure inside the blood side pushes water and small solute out of the fibers. Next slide, sir. Here I'm giving one example for conventions. See this first diagram. So whatever one is blood compartment is pressurized and water from the blood move across the membrane. And second diagram I'm showing result in the blood on one side of the membrane and water on the other side, which create a solute concentration gradient between the two components. And diagram number C, small molecular weight solutes diffuse across the membrane to equalize the concentration gradient. Note, rate of fluid removal depend upon the membrane permeability is related to the ultrafiltration force size and membrane material, membrane thickness. Next slide, sir. Principle of ultrafiltration. So working principle of ultrafiltration, I will discuss now. Majorly, this transmembrane pressure. What is transmembrane pressure? Driving force across the membrane. So driving force across the membrane, whatever pressure we are giving during ultrafiltration, it is called transmembrane pressure. So transmembrane pressure, it is depend upon blood inlet plus blood outlet pressure divided by 2 plus vacuum pressure, suction, suction negative pressure. So the transmembrane pressure is too high, greater than 500 to 600, membrane will damage. So we have to monitor carefully during ultrafiltration. So next one, sir. Ultrafiltration coefficient. It will measure how efficiency of water is removed per unit of transmembrane pressure. So rate of water removal to the transmembrane pressure for a particular device at a constant bleed. It will express it as ml per hour per mmHg. Ultrafiltration coefficient depend upon three things. One is membrane properties, blood flow, hematocrit, and protein levels. Membrane properties, if it is what material we are using in ultrafiltrations, and membrane thickness, if it is clotting something is there, it will prevent the ultrafiltration rate. If it is membrane is very thick, ultrafiltration is rate is low. If it is membrane is thin, ultrafiltration rate is high. Like it is like oxygenator only. If it is oxygenator is any clotting is there, oxygenation capacity is very low, like that. If it is any thickness something is there, more thickness in ultrafiltration, right, ultrafiltration is very low. And if it is ultrafiltration membrane is very thin, so ultrafiltration rate is very good. And pore size, membrane pore sizes, and blood flow. So if it is higher blood flow and higher ultrafiltration coefficient, and hematocrit and protein levels. So hematocrit and protein levels are low. So ultrafiltration rate is high. So next slide, sir. Note. So rate of ultrafiltration coefficient is 2 to 50 ml per hour mmHg. Ultrafiltration coefficient increases if it is transmembrane pressure increases, blood flow increases, and if it is low hematocrit. Greater than 25,000 deltons molecules are not removed by ultrafiltrations, like cellular elements, plasma proteins, and protein bound solute will not be removed and will therefore be concentrated. So next slide. Next topics, what is sieving coefficient during ultrafiltration? What is sieving coefficient? The sieving coefficient is a number between 0 and 1 that tells us how easily a solute dissolved substance can pass through the membrane of an ultrafiltration. So sieving coefficient means it is a ratio of concentration of solute in ultrafiltration divided by concentration of solute in plasma. I will explain. Next slide, sir. In simple terms, it compares how much of solute is present in the filtered fluid to how much in the blood plasma. Interpretation value. If it is sieving coefficient factor is 1, solute freely passes through the membrane, no resistance. If it is sieving coefficient of solute is 0, solute cannot pass at all through the membrane. If it is sieving coefficient of solute is 0.5, half of the solute in the plasma is able to cross. Next slide, sir. So sieving coefficient, it is majorly depend upon three factors. One is molecular weight, protein binding molecule, and one more thing, surface charge. If it is molecular weight of the solute, molecular weight is low. If it is low, sieving coefficient is 1, because like small molecules like urea, creatinine, and glucose, these are all molecular weight are very low. So this it will remove easily through filtration. This sieving coefficient of urea and creatinine and glucose, this is definitely 1. If it is large molecule, example albumin, RBC, immunoglobulins, so many proteins molecules, these are all big sizes, big size molecules. It won't be removed in ultrafiltration. This sieving coefficient is 0. Protein binding molecule. If a solute is bound to a plasma proteins, it become too large to pass. Only the free unbound portion can be filtered. So next one, sir. Surface charge of solute. If it is ultrafiltration, surface charge is negative. whatever negative charge particle solute is there, it won't be removed in ultrafiltration according to Sieving coefficient factor. Some membrane repel charged solutes, if a solute has a charge opposite to the membrane, it may pass easily. If it is if it is as a similar charge, it may be repelled and not filtered. Note, surface charge of ultrafiltration is negative. Next one, sir. Let's take one practical example. On urea for sieving coefficient. Urea is a small molecular weight molecule, and it is not a protein bound molecule, and it is freely passes through the membrane. Urea sieving coefficient is 1. Now albumin, it is large protein molecule and molecular weight also more, can't pass through the membrane. Sieving coefficient is 0. So next one. I'm giving some example. Urea is not protein binding molecule, and it is positive charge solute, and molecular weight is small. Sieving coefficient is 1. Creatinine is positive charged particle, and protein, it is not protein binding, and size also very small. Sieving coefficient of creatine is 1. So glucose also, it is positive charge molecule, and this one, it is not protein binding, size is small, and sieving coefficient is approximately 1. Calcium, calcium, some amount of calcium it binding with protein, so that's why it is not it is partially removed through ultrafiltration. This is a small size molecule, and calcium, this one, sieving coefficient is 0.5. Next slide, sir. Important note, what is the heparin status during ultrafiltration? According to sieving coefficient factors, coefficient factors majorly depend upon three factors. One is molecular weight of the solute, and one more is this one, surface charge of the solute, and protein mode. But heparin is highly negative charged molecule that can bind with proteins. So heparin is one thing is highly negative charged molecule and a protein bound molecule. Due to its properties, heparin may or may not be effectively removed by ultrafiltration. Maybe or may not be removed by ultrafiltration. Monitoring ACT level is crucial during cardiopulmonary bypass during CPB to ensure adequate anticoagulation and prevent complications such as thrombosis or bleeding. Activated clotting time, ACT, is commonly used to monitor heparin effectiveness during CPB. Next slide, sir. The according to half life topic, so half life of heparin is if it is low doses molecule means 30 to 60 minutes. If it is high doses we are giving means 1 to 2.5. During CPB, heparin half life can be prolonged due to factors like hypothermia, hemodilution, and altered renal functions. Monitoring heparin levels and adjusting dosing accordingly is crucial to maintain adequate anticoagulation and to prevent complications. Next, sir. According to sieving coefficient topic, heparin sieving coefficient is 0.5, not 0. Heparin is highly protein bound in plasma and negative surface charge for the limit passage. Note, in ultrafiltration hemoconcentration, heparin may not be removed, remains in plasma. Maybe it will remove in urine output. Because of low molecular weight, it will remove 50%. Indications and outcomes of ultrafiltration. Why ultrafiltration used during CPB? One main reason, patient on CPB undergo hemodilution because of blood priming. 1 to 2 liters we are using for crystal red priming, such as volume. This can reduce hematocrit level and serum protein level and overall blood concentration. And one more thing, additions of fluid enters from the circulation from cardioplegia solutions, surgical irrigation, and blood suction from the operative fields to cardiac suctions. These are all it will hemodilute it will hemodilute the patient blood. So these conditions, ultrafiltration techniques is very useful. So next one, sir. And ultrafiltration helps by removing excess water from the blood, concentrating red blood cells and plasma proteins without removing proteins, reducing fluid overload, tissue edema, and lung water, improving hemostasis, less bleeding, and reducing need for blood transfusion, decreasing time on ventilator after surgery. Next slide, sir. Here I am giving one example. Ultrafiltration, here patient blood volume 6000 ml is there. 6000. Hematocrit is around 17 is there. PRBC, we are adding through that patient. In 600 ml PRBC, contain hematocrit is around 60%. We are adding, so now blood volume become 6600 ml. Now hematocrit will become 20.9, and after ultrafiltration we did 6600 ml extra volume we removed. Now hematocrit is become 23. So this is one example. Just okay, so next one. Clinical situation where ultrafiltration is especially useful in patient with congestive heart failure or renal failure. They may have already high fluid volume. Patient is not responding to diuretics. Next one, sir. Technical applications, how we are using ultrafiltration during CPP, I will explain here. So ultrafiltration is done using hemoconcentrator, which has a membrane that allows water and small solutes to pass but remains proteins and cells. So configuration in the CPP circuit, how we will adjust this one. So ultrafiltration is usually set up in parallel to the CPP circuit, a side loop. Blood enters from a high pressure site, arterial, and after the pump, blood return to a low pressure site, venous line or reservoir. Next one, sir. How does blood flow through the ultrafiltration? Arterial, if it is arterial pump pressure, 150 is there like that. I will take one example. After we are opening ultrafiltration shunt, arterial blood pressure become 140. Now we are in 4-liter flow in 150 pressure. If it is, we have to increase ultrafiltration rate and patient pressure, means we have to increase some flows, and until it will become 150. So it will increase the ultrafiltration. When you are open the shunt to the ultrafilter, blood is diverted away from the patient, arterial pressure drop to maintain normal pressure to the patient to increase pump flow. The extra pump flow equal the amount of blood being filtered out. Means this one, if it is, sorry, that's like, if it is we are doing before starting ultrafiltration, we need to check line pressure. If it is line pressure is 150, we starting one we start ultrafiltration means it should be become 150 only, because flows will reduce to the patient. So that's why, so arterial pump pressure, yeah, we need to maintain during ultrafiltration. Before we need to check before starting ultrafiltration. So next one, sir. And common misconception, everybody is using clamping the outflow of the ultrafiltration. Outflow means this one outlet of the ultrafiltration. So everyone will think ultrafiltration rate will increase, but it won't be increased, because ultrafiltration flow will decrease. It will reduce the flow, and ultrafiltration rate will decrease actually. And effluent and filtered fluid removal. The filtered water goes into a collection consister, means suction jar. The flow rate is enhanced by hydrostatic pressure gradients. The consister is placed lower than the ultrafilter, 60 to 90 centimeter height difference, around on 45 to 65 mmHg pressure. Optionally, a vacuum can be applied to increase flow. Next one, sir. Caution, fluid shifts and hypovolemia. Rapid fluid removal can cause intravascular volume depletion, but on CPB, this is well tolerated since the bypass pump controls circulations, not the patient heart. Also, as osmolarity increase in the blood, water shifts from tissues to blood natural rebalancing. Next, sir. Uh, Now I'm discussing types of ultrafiltration. So there are four types of ultrafiltration: pre-bypass ultrafiltration, conventional ultrafiltration, zero balance ultrafiltration, modified ultrafiltration. Next one, sir. What is pre-bypass ultrafiltration? Uh, Pre-bypass ultrafiltration can be done while priming. Actually, we are using additional like blood FFV while priming, especially in pediatric patient. It is a very useful technique. Following addition of blood to the CPB circuit, ultrafilter removal is initiated and volume replacement with a balanced electrolyte solution. It will reduce the bradykinin and factor 13 prekallikrein. It will eliminate the initial drop in blood pressure commonly seen with the initiation of CPB, and it will reduce the hyperkalemia, and it will regulate the blood sugar level. It is very useful technique for pediatric. Oh, so next one, sir. Conventional ultrafiltration. CUF is a technique of ultrafiltration performed during cardiopulmonary bypass, where plasma water and small solutes are removed through a ultrafilter while returning concentrated blood back to the patient. Key features. Initiation. CUF become possible when a large cardiactomy reserve volume allowed continuous circulation and ultrafiltration. Next one, sir. Timing. It is usually performed throughout CPP, most often begin during rewarming phase, and when fluid overload and hemodilution are most concerning. And more majorly, we are using in ultrafiltration in our center after cardioplegia delivery. After cardioplegia delivery, we are using this cuff method. We will start because patient become more hemodilution in that conditions. If it is volume overload, that condition also we are using. Rewarming paste we are using. Applications commonly we are applying in adult and pediatric both. I didn't mention, sorry. So large priming and reservoir volume. Pre-operative renal dysfunctions. If it is any chronic renal dysfunction is there, we are using ultrafiltration to avoid excessive fluid overload and help in fluid balance. Next, next one, sir. Ultrafiltration is a small note I'm given. Conventional ultrafiltration is an intraoperative fluid management strategy used during CPB, especially in adult with large reservoir volumes or renal impairment, mainly started in the rewarming phase to reduce hemodilution and optimize fluid balance. Next one, sir. Here I'm giving one small circuit diagram here. From the patient, venous reservoir blood will come. Uh, it is going to the perfusion pump, and after that it is going to the membrane oxygenator. So membrane oxygenator, one recirculation line, we are connecting ultrafiltration. So after ultrafiltration, it is again it is going to the cardiactomy reservoir. So whatever filtration fluid we are collecting in suction jar, fluid collector. Next one. Conventional ultrafiltration advantage. So this one, no delay in surgical times. Cuff is performed simultaneously during CPB without extending bypass duration. Removes ultrafiltration during peak mediator release, helps clear inflammatory mediators, examples cytokines that are produced maximally during CPB, potentially reducing systemic inflammatory response. And if it is low hematocrit and high fluid overload, it will be very useful. Disadvantage, risk of rapidly emptying the reservoir. It will empty rapidly. So continuous filtration may cause sudden decrease in the reservoir volume. If we are not carefully, we should carefully monitor the reservoir level. So next one, sir. Next one is zero balance ultrafiltration concept and purpose. Zero balance, it is a technique used during CPB where plasma water is removed by ultrafiltration and replaced with an equal volume of balanced electrolyte and solution, keeping the patient isovolemic. If it is patient reservoir volume 600 ml is there, means we'll keep 600 ml only. Whatever addition fluid we'll remove. If it is 50 ml plasmolate we are adding in, for example, 50 ml plasmolate we are adding in reservoir, means reservoir volume it will become 650. So that 50 ml only we should remove. So this is called zero balance ultrafiltration. Whatever fluid we are adding, that should be balancing. Primary goals of ZBUF. ZBUF reduce inflammatory mediators. Example, cytokines and complements. Inflammatory mediators it will remove. And one more thing, after delivery of cardioplegia and after transfusing PC, blood something, it will correct the hyperkalemia. It will reduce the excess solutes like citrate, lactate, potassium from blood prime, especially important in pediatric CPB. Maintain fluid balance while filtering out harmful substances. Next one, sir. Key principle: solute in plasma water, electrolytes or urea, example, are removed in the same concentration they are in blood. Proteins and cellular elements are retained. Ultrafiltration is replaced, when ultrafiltrate is replaced with an equal amount of electrolyte solution, hemodynamically stability is preserved isovolemia. How ZGOF work technically? Effluent ultrafilter tubing and replacement fluid tubing are loaded in opposite direction into a single roller pump. This setup ensures the volume out equal to volume in, especially useful during rewarming phase when inflammatory mediators peak. Next one, sir. Replacement solutions. What are the solutions are useful in this one? Example, if it is potassium is normal, this plasmolite and RL is better for a patient to maintain to removing inflammatory mediators. It is suitable for removing cytokines and inflammatory mediators, but these solutions contain plasmolate and ringerlactate, contain potassium, and it is contains acetate and lactate to help to maintain acid base balance. But contraindications, patient with hyperkalemia, not hypokalemia, hyperkalemia due to its potassium content. In hypokalemia conditions, we are not using, we can't use this solution because these solutions contain potassium and 0.9% NS. This one NS preferred for correcting hyperkalemia. It is very useful in hyperkalemia corrections. Potassium content is 0 milliequivalent actually. Uh, if it is used no potassium content, make it safe for a hyperkalemic patient. And contraindications, it is not contain any buffer system. So lack of buffer can lead to hypernatremia and metabolic acidosis with large volume infusions. Next, sir. And one more thing, sodium chloride plus bicarbonate solutions. If it is 500 ml NS is there, we're adding that 500 ml NS to 20 milliequivalent this one bicarbonate. So then it will balance actually. Used when buffering capacity is needed alongside sodium corrections, like this. Sodium content is 174. In sodium 0.9% NS is contain 154 milliequivalent per liter. We are adding 20 milliequivalent, it will become 174 milliequivalent per liter total sodium. This in the solution. Use it is adds using in adds buffering capacity to correct acidosis. Contraindication can cause rapid sodium shifts requiring close monitoring to avoid complication like fluid overload or electrolyte imbalance. Next, sir. Risks to monitor using NS for ZBUF. Hypernatremia from high sodium content, magnesium and calcium depletion, hyperchloremic metabolic acidosis, it will be happen. Uh, Central pontine mineralolysis if sodium corrected too fast, greater than 2 milliequivalent per liter per hour. So note, what is central pontine mineralolysis? It's a rare neurological disorder characterized by damage to the myelin sheath in the pons area of the brainstem, causes rapid correction of hyponatremia, low sodium level, and other electrolyte imbalance. So next, sir. Special consideration in pediatric. Pediatric patient have small blood volume, less than 400 ml. Prime volume of CPB circuit is disproportionately large. ZVAF is used before CPB to clean the prime, like remove potassium lactate citrate using electrolyte replacement fluids. Means free bypass ZVAF is very useful, like on some 300 ml, 150 ml PC were adding in CPB pediatric CPB circuit means we did some free bypass ZVAF means it will remove potassium lactate and citrate. It is very useful for pediatric patient. So next one, sir. Effect on lactate level. So how this lactate level will decrease during ZVAF when bicarbonate based solution is used. Example, bicarbonate plus NS or plasmonate. So lactate is filtered out effectively. So no lactate added back in because result lactate decreased significantly because acid base will balance and pH level will increase and base excess also will increase. pH level is we are maintaining pH level and base excess means lactate level significantly decreases. Next one. When ringer lactate is used as a ZVAF, what happen? RL contains 28 millimole per liter lactate. While filter removes lactate infusion adds lactate balance depending on ultrafiltration rate versus infusion concentration. Result: lactate may not fall much or could even rise slightly. Acidosis correction less effective compared with bicarbonate. Hemodynamic effect by lowering lactate ZVAF helps reduce metabolic acidosis, which otherwise deflates the myocardial contractility and the systemic vascular resistance. Next one, sir. Then I'm going to modified ultrafiltrations. So modified ultrafiltration, MUF is a post CPB technique used mainly in pediatric heart surgery. It is helps to remove excess fluid and inflammatory mediators from the patient blood after the heart lung machines has been stopped. Unlike traditional ultrafiltration, which is done during CPB, MUF is performed after bypass is discontinued while the patient is still cannulated and connected to the extracorporeal circuit. Means MUF after coming off we are doing MUF. This one especially pediatric patient it is very useful. This one it is very useful and but one major we need to wait for a muff. Actually patient is still cannulated, uh, still patient pump is not disconnected like that. We need to we need to wait for 10 to 20 minutes for a muff. So that is the one uh, contra this one. So next one. Why muff is needed? If it is in pediatric CPB, the prime volume of the bypass circuit is often larger relative to the child's blood volume, leading to hemodilution. This causes low hematocrit, tissue edema, and low blood pressure after CPB. The inflammatory response to the bypass can also cause organ dysfunctions. So next one, sir. MUF is helps to concentrate the blood, remove water, inflammatory mediators, and waste products, improve the post-operative heart and lung function. Next, how MUF will be performed? After the CPB ends, the patient remain cannulated. A roller pump or cardioplegia pump draws blood from the arterial cannula. Blood is passed through an ultrafiltration membrane. Water and solute filter are removed. Concentrated blood is returned to the patient via the venous line. Crystalloid is added to the reservoir as needed to maintain flow. So next one. Here I'm showing MUF circuit. If it is with pump, here venous reservoir is there. Uh, here from the aorta, patient blood will be come and it is going to the cardioplegia pump. Cardioplegia pump means ultrafiltration pump, and it is going through the ultrafiltration. And after ultrafiltrating fluid, it is collecting in suction jar, fluid collector. After ultrafiltration is done, it is going to the right atrium directly. So next one, sir. So MUF will last about 10 to 20 minutes. We are doing technical setup. It will require separate ultrafiltration circuit, roller pump or cardioplegia pump, ultrafiltration membrane. Some setups are pumpless. In our institute, we are using venous MUF. It is pumpless. We are not using any pump. According to arterial pressure, we are using in our institute. Using the only pressure difference arterial and veins. Venous MUF is an option, but is less efficient due to recirculation. Next one, sir. Key challenges and risk. Air embolism risk. Arterial line must be checked for air. What are the key challenges? If it is while starting MUF, we need to check arterial and venous line. It should be clear. Any air is there, it is a risk. Okay, air embolism risk is there, and negative pressure assault. Kings or clamps in the arterial can cause air internment. Delayed protamine administration. One more thing, if it is MUF we are doing, they can't anesthesia side, they can't administer this one protamine because patient is remain cannulated. Since the patient remains connected to the circuit, protamine heparin reversal is delayed until MUF is complete. Next one, sir. Effect of eye MUF flow rates on the brain. What is the effect if it is some institute they are doing with pump? So what are the majorly it will affect? So MUF should be less than 20 ml per kg for majorly in infants. What happen if it is in modified ultrafiltration? Blood is typically pulled from the arterial cannula, passed through an ultrafiltration membrane, and returned via the venous cannula. To increase the efficiency, that is, remove more fluid in a shorter time. Some clinical use higher MUF blood flow rate, especially in small pediatric patients. So next one. Next one, sir. What is the problem in eye flow? I will tell. Key concern: cerebral blood flow compromise. When eye MUF blood flow rates are used in infants less than 10 kg, there is a risk of increased aortic diastolic run-up. This means that during diastole, when the heart relaxes, more blood than is normal is pulled away from the aorta into the extracorporeal circuit. Normally, during diastole, blood perfuses vital organs like brain and coronary arteries. During diastolic conditions, coronary artery and carotid artery, it is getting more blood. In MUF, it will come back to the circuit. More flow we are giving means what happened? Uh, this one, sir. It will run blood is run away from the aorta. This runaway reduces the pressure and flow available to the perfusion to the brain. This runoff it will reduce the brain perfusion. So next one, sir. Uh, this one, and it will cause intracranial steal phenomena. Steal phenomena. So what is that steal phenomena? The term steal means blood is diverted away from the brain due to a pressure gradient caused by the extracorporeal circuit. If MUF flow is too high, blood is pulled from the aorta too quickly, stealing it from cerebral circulation. This result in hypoperfusion of the brain. So next one. Regarding, I'm referring gravely this one. Regarding study populations, pediatric patient less than 10 kg, what they tested various MUF blood flow rates findings. At MUF flow greater than 20 ml per kg per minute, they observed cerebral blood flow velocity is decreases, and cerebral mixed venous oxygen saturation also will decreases, and it is cause hypoperfusion to the brain. Next. Conclusion: IMF flow rates in small children can reduce brain perfusion, posing a neurological risk. Clinical implications: keep muff blood flow less than 20 ml per kg per minute in children, less than 10 kg to avoid compromise cerebral oxygenation. I'll give one final analogy. Think of the iota as a highway and muff as a fast vacuum cleaner pulling traffic blood. If the suction is too strong, high flow, the brain exit lane does not get enough cars blood, and traffic to the brain slows down or stops. This is the steel phenomenon. Just like too much suction could damage something delicate, too high muff flow can reduce oxygen to the brain. Next one, sir. Benefits and outcomes. What are the benefits are in MUF? You see, hemodynamic stability, increase the hematocrit level, higher arterial. It will increase higher arterial pressure, improve cardiac output, and respiratory side, it will improve the lung compliance, and it will reduce the ventilator time, and recovery, reduce the post-operative bleeding, and it is lower the blood transfusions, and it will and shorter ICU stays. So next one, sir. And myocardial effect, it is improve the myocardial contractility and less myocardial edema. Immunological, it is remove the inflammatory mediators. So next one, sir. And summary of MUF. When done after the CPP, and main goal, remove fluid and toxins, concentrate blood, and tools used: ultrafiltration roller pump or cardiopulmonary pump. Sometimes pumpless muff also we are using, that is called veno-venous muff. Duration of muff is 10 to 20 minutes. Main benefit: it will increase the hematocrit level, decrease the edema, and decrease the ICU time. And main population: pediatric patients. We are majorly we are using. Challenges: air embolism, delayed protamine, negative pressures. Thank you, sir. So next one, sir. Thank you.
Okay, so thank you, Sachin, for delivering such a insightful live presentation. It was a wonderful topic, and now we are open for the Q&A session. You can ask your questions in the live chat. So we'll pick the questions, and Sachin will explain the questions. So we have few questions over here. Okay, so Sachin, you can see the question, or should I read it for you?
I want to ask position of when we are using the centrifugal.
So the question is, I want to ask position of ultrafiltration when we are using the centrifugal pump.
Uh,
So yeah,
we are using centrifugal pump. We are using means definitely we need a extra pump, because
okay,
centrifugal pump, it is depend upon preload and afterload, and if it is
yeah,
resistance is more, centrifugal pump flow is very less actually. It is not going to other way. This one. And centrifugal pump is majorly depend upon RPM. If it is
okay,
RPM is and RPM and iotic resistance. If it
yeah,
is RTL is more resistance, the centrifugal pump pressure is high
yeah. Pressure
because
pressure is not created with centrifugal
uh,
pump for the
yeah,
filtration.
yeah,
So we need a roller pump, right?
yeah, we need separate roller pump
Yeah,
for
roller
this
pump.
one. Roller
So
pump separate we need.
okay, so in that case, it is not possible to do filtration with centrifugal pump, is it?
Yes, sir. Yes, sir. We will do, but we can't predict how much it is going to ultrafiltration, because
Yeah, yeah,
in roller pump means we have to see line pressure and all. But
yeah,
this one is preload and afterload dependent pump.
yeah.
So that's why this is
Okay, so this question is from Priyanshu from India. Okay, so thank you, Priyanshu, for asking the question. We'll go to the next question. So the question is, when is the best timing? Can hemofiltration be activated during CPV? When hemofiltration is running, but the hemofiltration output line is closed, does hemofiltration still provide any benefit?
in the. Sir, can you explain this question?
Yeah,
In the
so I'll explain. Yeah. When is the best timing to start the hemofiltration on CPV?
Sir, after delivering cardioplegia, one thing,
Okay.
if it is we are using Denlido cardioplegia, so that time hemofiltration is very benefit because lot of blood this cardioplegia volume it will come, and if it is patient having large volume, if it is
Okay.
dilated LA, LV something, with DVR plus TB repair like that cases and all, patient is having a more large volume, so that time we will start ultrafiltration. And one more thing, patient hematocrit is less, so that time also it is useful
Okay.
for removing. And rewarming time ZWAF is useful actually. In rewarming time, most inflammatory mediators start in rewarming period only. So that time ZWAF also
So,
useful. And after
uh,
delivering cardiac
okay.
is also useful.
Okay. During rewarming.
During rewarming, ZWAF is useful. If it is after
Okay.
delivering cardioplegia, cuff is useful. And
Okay.
if it is potassium is high, ZWAF is useful. Right.
Okay. So when hemofiltration is running, but the hemofiltration output line is closed, does hemofiltration still provide any benefit? So during hemofiltration,
Uh,
when the output line from the filter is closed, does hemofiltration provide any benefit?
Sir, actually, if it is suction line is open, means if it is hemofiltration outlet line is closed means, according to transmembrane pressure, so blood flow through the hemofiltration it will reduce.
Okay.
Then no benefits, sir. Actually, it will reduce the hemofiltration rate. Actually, hemofiltration is majorly depend upon the
But
blood flow.
I guess we can partially clamp the line, output
No,
line.
sir. But my suggestion, I'm thinking what I'm because according to transmembrane pressure, so hemofiltration blood flow it is majorly depend upon blood inlet pressure plus blood outlet pressure
Yeah.
divided by two plus this one vacuum pressure. This blood inlet pressure plus blood outlet pressure divided by two plus vacuum pressure. Vacuum pressure is most important, sir, for filtration. We are applying outlet pressure; it will reduce the blood flow. It won't increase.
Okay.
Instead of we are clamping outlet, where you apply a vacuum to the suction jar, that is useful, sir,
Okay. So we'll go to the
according
next question.
to transmembrane pressure.
Okay. Okay. So we have one more question. How to correct sodium and calcium levels,
Sodium
except
chloride, calcium.
sodium and calcium levels, except adding sodium bicarbonate, without adding bicarbonate.
We will do this one. NS ZBUF, sodium chloride ZBUF with 0.9% full NS. That will correct. Calcium after it will decrease because
Okay.
it is
Yeah, we
because of
can add calcium. Okay.
calcium after CPB also we need to add.
Okay. So we have one more question. It's from Malvika. How to calculate cuff and muff filtration volume?
Sir, if it is we are going to start cuff means one more thing, if it is 1.5 liter, we are administer some 1.2 liter crystallized solution we are administer in this one cardioplegia something. We are giving some 300 ml blood is there. So 1.2 liter we remove during a cuff. We are removing some 1.2 liter cardioplegia volume, and we have to see the suction jar volume. Whatever suction we are getting, how much we did cuff for, and after CPB, this one before starting muffing, we will empty the suction jar, and we'll see the how much muff we did like that.
Okay.
And according to whatever we are adding, how much we are removing, that also we have to calculate. And urine, and how much urine is came like that.
Okay. So we
Majorly we
have,
have to suction jar only.
okay. Okay, we have one more question. It's same. So it's from Mokhtar Izri.
Uh,
Izri, he's from Algeria.
uh,
And what is the limit volume to be filtered?
no, limit volume and all not there because depend upon fluid administration, depend upon this one. Case we will do muff actually. Sometimes CPP goes 300 minutes also.
Yeah.
Sometimes it will start bypass also. That limit is not possible actually. because sometimes 300 minutes bypass means we'll admit more cardioplegia and blood will dilute more. So we can't
Okay.
predict that limit volume.
So there is no any defined limit or volume for that.
Limit volume is not there for my suggestion because
Okay.
according to case it will depend. And
Okay.
if it is a patient hematocrit is good, we can't filter that. And hematocrit potassium level.
Okay. So we have one more question. What is ultrafiltration strategy in cyanotic patients with higher crit levels?
Higher crit levels, we are using ZBUF. ZBUF is benefit
Okay.
actually.
So ZBUF, is it
ZBUF is
yeah, is
because
it
we are
necessary for?
administering
Okay.
cardioplegia. One more thing, and whatever inflammatory this one some FFP and R we are using for priming and some inflammatory mediators it will release. No? So ZBUF is a benefit for higher hematocrit levels.
Okay. So ZBUF is necessary for all the patients? Is it necessary for all the patients?
Yes, sir. It is good actually. If it is any inflammatory, yes, sir. We
Because
will do. Uh,
see,
uh,
because we are
according to
observing.
electrolyte level, we have to see, sir. If it is potassium is too high, we'll use ZBUF. And rewarming time, it is you are using means benefit is there because inflammatory mediators that time only goes up.
Okay. Because we are if we are doing cuff and muff, I
Mm.
think we are removing most of the fluid.
Yes, sir.
So is it necessary to do
No, sir.
ZBuff?
No, sir, not necessary, but because of inflammatory mediators, want to remove that rewarming time we will do. Not necessary.
Okay, okay, okay. We have one more question. So it is from Nawang. He's from Indonesia. So his question is, what is the strategy if the patient has an additional diagnosis of chronic kidney disease, CKD patient during CPV?
Oh,
So what is the
okay.
strategy for CKD patient during CPV?
Uh, CKD patient. We
Chronic
will
kidney
do.
disease.
We will use definitely we will use ultrafiltration techniques. And one more thing, we'll see this one potassiums and electrolyte balance we need to see. And MUF is benefit for this patient actually because after CPB, it it will instead of diluted blood is going, we have to send a filtration. That is
Okay.
benefits.
Okay. So we have one more question. Mm, Okay. So it is from Dr. Abdul Rahman Ahmed Alaili. Okay. How many ml we can take out from pediatric and infants in MUF strategy?
Around 50 ml, 50 to 20, some 20 to 100 ml. According to this is depend upon according to patient weight and patient
Okay.
arterial pressure.
Okay. We have one more question. It's from Naveen. He's from India. During modified ultrafiltration, uh, arter- if required arterial temperature or not. So his question is during modified ultrafiltration,
Mm.
is the arterial temperature
Yeah, temperature is required or not. Means if it is temperature is not if it is not required actually because
hmm,
MUF already almost we done after during after rewarming only after post CPP. Temperature is not required.
yeah, okay. Okay, so we have one more question. It's from Indonesia. Um, what is the maximum flow that can be delivered in MUF? What about in obese patients?
Uh, all patient we are using according to standard protocol 15 to 20 ml per kg per minute for MUF maximum flow. If it is more greater than 20 ml per kg, This one it will cause cerebral steam.
Okay.
And according to arterial line pressure also, sir. If it is arterial pressure line pressure is good, will increase muff flow.
Okay. So we have one more question from Naveen. During MUF, arterial temperature is required or not? What is the correlation between rewarming target temperature management according to MUF?
Sorry, sir, I'm not understanding this question actually.
So his question is he had asked the question previously, so it is the same question, but what is the correlation between rewarming target temperature management during MUF? What is the
According,
correlation between temperature management for MUF?
what is the correlation? Means
Why is the temperature important during MUF? Is
temperate. No, what is no, no, sorry. Is the question is of arterial temperature if it require or not? What is the correlation between rewarming target temperature management according muff? Sir, actually, this one muff we are after muff we are doing after CPB only. Whatever rewarming blood only it is coming to the uh, this one ultrafiltration only. It won't be cooled, so that's why it won't be required actually. We are not cooling the that blood is warm only. If it is we are using any cardioplegia pump, some BCD something, so that time
okay?
it will require because that BCD is cooled. But here RT, if it is venous muff and all we are doing means directly from ultrafiltration pump we are connecting means that time temperature management is not required actually.
Okay.
Because already we are seeing this one and during muff we are flowing less amount only that small amount of temperature it won't be affect patient temperature.
Okay, so we have one more question. It's from Uzma Mazhar, and her question is: can we use dialyzer if hemo concentrator is not available?
We can use, sir. We can use.
Okay. Is there any specific strategy for that? Do we need to like follow any specific strategy or any special
No, sir, same
considerations?
circuit only, same circuit only.
Okay.
Same strategy.
Any pressure changes or something?
No, sir, no, sir.
Okay. Okay, we have one more question from Noora. If there is less reservoir volume, like in hypovolemic patient, we want to do cuff, but ABG values, uh, do we not do cuff and directly muff after CPB? So did you
What
did you get the question?
if there is less reservoir volume like in
Yeah, if
hypovolemic
the volume is low,
uh,
can we avoid cuff and directly do muff?
there is less reservoir volume like in hypovolemic patient we want to do muff because ABG values. Uh, do we not do muff cuff and directly muff after CPG? Sir, here cuff we will do, sir, because if it is patient crit is low, we will add some 250 ml PC something, blood something. So after that, blood whatever blood we are adding, na, so that 250 ml we can remove during cuff.
Okay.
And muff is depend upon patient arterial blood pressure actually. It won't be affect that reservoir volume is not affect that directly muff.
Okay. So we have one more question. What's your opinion on Z buff in all cases for better lactate clearance and decreased inflammatory response?
Uh, ZCOP is very very useful for correcting hyperkalemia and one more thing, whatever ZBuff you are using, no, you have to use if it is hyperkalemia, it's not there. We'll use some plasmolite. Some
Okay.
buffering solution we will use plasmolite. This plasmolite it won't cause any acidosis actually. If it is acidosis is not there, so patient perfusion is good actually. So that time lactate clearance is very good. And if it is inflammatory mediators during rewarming period, this inflammatory mediators start peaking. So that time is very high, and that time ZBuff is useful. And one more thing, pre-bypass ZBuff means we are adding PC and FFP to the pump, to the circuit. So that time some inflammatory mediators are there. So that time we are using this one ZBuff means that is useful actually. It will remove hyper and potassium also. ZBuff that condition is very useful, sir.
Okay, okay. So we have one more question. If muff is done for more than 20 minutes, does it have a good impact or not?
If it's monthly, so done for more than 20 minutes. According to my experience, we are doing 10 to 20 minutes maximum, sir. But it's okay if it is arterial pressure is good, we can do. Uh, but it is good only. But we have to see the this one, and it will take more time actually. 20 to 30 minutes means it is 20 above minutes means it will take so much time.
Okay.
Time management is not good actually,
So
because
according to you, what
patient
is the
is cannulated, and patient this one what blood will stagnation is there, because it will move slowly in muff circuit.
okay,
That's why in reservoir volume it will stagnate that blood, and more than 30 minutes 20 minutes maybe it's not beneficial, because according to patient remain cannulated, and patient surgery will delay, and that is I'm telling.
okay? So what are the indications for muff and zero buff?
Muffs are sir, muff if it is it will remove post-operative this one, for
No,
post-operative inflammatory mediators,
that
and
is that is the effect. But what is the indication? Means in which patients do we need to do muff and zero
mostly
buff?
in pediatric patient, because uh, patient is small actually, and patient heart
Okay.
also very small. It is hypervolemia means heart will get distended. So that
And
time
what?
is
Okay.
Murphy's benefit. And one more thing, overall, if it is during CPB, overall getting some low hematocrit, so
Okay.
that patient also it will benefit actually.
And what
ZBUF,
about?
ZBUF
Hmm,
during hyperkalemia is there. So that patient for correcting hyperkalemia, ZBUF is benefit. And for lactate is high, that time also some this plasmolate ZBUF is benefit. And one more thing, if in rewarming phase, this for removing inflammatory mediators, this ZBUF is benefit. And
okay.
pre-bypass ZBUF, while adding PC or FFP during pump, it will release some inflammatory mediators, and this one lactic acidosis, metabolic acidosis should be there. It will remove
Okay.
during pre-bypass interpretation is benefit. Pre-bypass
Okay.
ZBUF.
And what about if the patient is having CKD or severe PH?
What's it?
If the patient is having severe PAH and
Severe
CKD,
pH.
yeah,
Severe pH. High or low, sir? I'm not understanding. pH is lower.
severe. If the
So,
pH is high, pulmonary hypertension is high,
okay, sir.
so which is the best strategy for the this patient?
For bed strategy, we will use this one. pH is I means we will use without buffer system solutions like NS. It is benefit actually. It will decrease this one buffer this
Okay.
bicarbonate level, because
We
it is
can
not
add
contain
other solutions also like plasma light. Is it?
plasmolite. It is contain buffer actually. Maybe it is not benefits, because it is having 6.5 to 8 pH is there in plasmolite.
Okay. Okay. So we have one more question. It's from Ashar Habib. He's from Pakistan. So his question is zero buff is only used for hyperkalemia?
No, sir. For removing inflammatory mediators also it will useful, and for removing lactate also it will useful, and so many benefit is there, sir. And not only hyperkalemia.
Okay. Okay. So we have covered all the questions, and it was a wonderful session. And thank you once again, Sachin, for the wonderful presentation. And you have answered a lot of questions and cleared all the doubts. So we thank you once again for joining with us, and we hope we see you again with another topic and with
Okay.
another presentation.
Okay, sir.
And all the best for your future, and
Okay, sir.
all the best.
Thank you, sir. Thank you. Thank you for
Yes,
giving opportunities, and overall participate here. Thank you for this one.
yes.
Okay.
Uh, there are a few more questions coming.
Okay,
I think we can pick
okay,
these questions also if you have, if you don't mind.
okay, sir. Okay, sir. Take.
Yeah, we have one more question here. Can pediatric patients use ultrafiltration for adult patients? What are the impacts? Can pediatric patients use ultrafiltration? I think the question is not clear.
Question is not clear.
Yeah. So we'll go to the next question. Okay. Can we do MUF on adult? Uh,
Adult a single
a
venous line
single
circuit,
venous line circuit
two-stage
with two-stage
cannula.
cannula.
So we
Yeah.
can do it, sir. But in between, we need to connect one connector. Actually, this is half line is there in adult A circuit. We need to connect half straight connector with lever lock. That is also best strategy we can use. One
Okay.
connector we have to use it. That is practical question actually. It's okay. We have.
Okay. So one more question is there. Okay. Very informative presentation. And can we elaborate the difference of cuff done by hemoconcentrator or dialyzer? Because mostly we are giving positive pressure in hemoconcentrator while in dialyzer vacuum is used. So what would you say about this?
What's that? What I elaborate the difference of cuff done by hemoconcentrator like this. Because
Difference between cuff done by hemoconcentrator and dialyzer.
so a difference maybe urea compared to dialyzer, our this one hemofilter is benefit.
Yeah.
So this one our hemofilter effectively it will remove this one
Depends on the
urea and
membrane. Yeah.
membrane. Urea and creatinine it will remove effectively compared to this dialyzer machines. Dialyzer machines is very low, and it will require so much priming volume also compared to our circuit, not required that much priming volume compared to, and
Okay.
it is very simple.
Okay. So we have one more last question here. Can we use zero buff for other electrolytes?
ZWAF majorly we can use, sir, according to this one. If it is balanced, this one iso volumic fluid we can use, sir. ZWAF like RL or plasmolate we can use for correcting other electrolytes also, because they contain this one volumic fluid we can use for ZWAF for correcting other
Okay.
electrolytes.
Okay. So thank you, Sachin.
Okay, sir.
Uh, it was a wonderful session, and we are happy to have you live with us. And wish you all
Okay,
the best again.
okay, sir.
And thank you
Thank you,
guys
sir.
for joining in the live session. And if you have any suggestions, you can directly DM us on Instagram or on WhatsApp. You can share your suggestions, or if you want any special topic to be discussed in the live session, you can comment in the live chat or you can directly DM us. So thank you for joining and see you in the next session. Thank
Okay,
you
sir.
all.
Sir, and one more
Yes,
thing, one person is asking is
yes,
this one centrifugal pump,
yes,
this one, and
yes.
centrifugal pump cuff we are using in ECMO side also we are using, sir, cuff,
Yeah, in
but
ECMO we are using
we are
centrifugal.
using, but what happened this one because resistance is more, the tubing size is that
Yeah.
cuff this one ultrafiltration tubing size is very small actually, it won't be effective. So after we are using so many days, it will clot actually because of resistance.
Okay.
So that's why maybe in centrifugal form, ultrafiltration technique is not that much benefit, but because it will create more resistance actually. Because tubing size is very small, it will create
Yeah.
more resistance.
Yeah.
That thing. Okay, sir.
Okay. Thank you,
Thank you.
Sachin.
Okay,
Thank you
sir.
for your wonderful presentation and wish you all the best. And thank you
Okay,
guys for joining. See you in the next session.
okay, sir. Thank you.
Okay.